Thank you all for logging on. This is our first presentation of the Speed Journal Club from the Journal of Pediatric Rehab Medicine. We can go ahead to the next slide. And so today, hosting Speed Journal Club, myself, Dawn Dykey, and Dr. Deb Gabler are moderating, along with the support from the JPRM of our editor-in-chief, Elaine Pico, and the managing editor, Sarah Tinsley. Speed Journal Club, if you haven't been a part of it or haven't heard of it, is meant to be a journal club where multiple articles are presented rather than just focusing on the depth and information of one or two. We're going to go over 5 articles presented over 5 minutes each. And so really a total of about 25 minutes of information. And then really the bulk of our time spent discussing after the articles are presented. And then from this slide, I can tell Lydia Singerman is actually an incoming fellow coming into the Children's Hospital of Philadelphia. Ciela Nimmo is at the University of Michigan currently. Nova Hu is finishing up at the Shirley Ryan Ability Lab. Annie Ibram is the current fellow at the Children's National Fellowship, and Nayun Kim, I believe, is outgoing from the Shirley Ryan Ability Lab. And so we'll hear an article from each of them tonight. We'll also have a warm introduction about the journal from 2 of our guest editors, one of them being Dr. Shruti Thomas, and Justin Ramsey have been able to join us tonight. So we'll get to hear a little bit of insight from the guest editors about the articles prior to the 5 articles that we're highlighting. And maybe,
oh, go ahead. I didn't know when you wanted.
Yep. And Deb, if you want to give us some more information about the journal and about the importance of our work tonight.
Absolutely. Thanks, Dawn, and thanks, Sarah and Elaine, for having this opportunity available to the fellows. And we know that the Journal of Peds Rehab Medicine is very important to our field of pediatric rehab medicine. It helps us define our content in terms of our knowledge base. It was started by Jay Neufeld. It seems like a long time ago, but I think it was first available in 2008. Elaine Pico has become the managing editor since 2018. It's distributed to many libraries, hospitals, and institutions worldwide. It's accessible throughout the many countries globally. We have external content providers and aggregates like EBSCO and Information Services, open access since 2023, and subscriptions are available. It has impact factor listed that we are always boosting, and Elaine has done a remarkable job in creating a very what we hope is an easy to submit and easy to access journal for our publications. I happen to be the first editor for the targeted issue for cerebral palsy, and I think I did it for about 4 years, and then I was happy to see upcoming talent take on the task, and it's really been a very important aspect. And so I was very thrilled that cerebral palsy was the topic chosen to be the first Speed Journal Club. Next. We've got a lot of abstract and indexing coverage. And I wanted to invite Elaine, if you want to say anything else about the journal so that you can encourage everybody in their scholarship.
I was afraid that was going to be a New York Times Connections thing there. That would have been. So anybody play that?
Hi.
No, we don't have to play that game. But this is to impress you in terms of this is a real journal. We're really making a part of a contribution to what we hope is the medical literature.
So Deb and Don, I want to thank you both, and I want to thank everyone who's here and our presenters today. This is a wonderful presentation of work from the cerebral palsy issue this year. And also Heck Young Kim is on, and she's one of our special guest editors as well. And Justin Ramsey, as well as Sruthi Thomas are here. And hopefully I'm not leaving anyone else out from our special issue. It's not my intention if I did. So welcome everyone, and I'm going to sit back and listen along with everyone else.
Thanks, Elaine. Sarah, go ahead on the next one. So I think, as mentioned, this is our Journal of Peds Rehab. We are at volume 17, and this is the first issue of volume 17, which is the highlighted issue of cerebral palsy. The team that works on graphics for the JPRM does a fantastic job of highlighting different types of articles that are discussed. We're not touching on all of these, but 5 of the ones that the fellows themselves have been able to pick out and present. Go ahead to the next one. And this is a warm intro and welcome from, I think, 3 of our guest editors, Dr. Thomas, Dr. Ramsey, and Dr. Kim.
Awesome. We're so thrilled also to have been selected for the first Speed Journal Club. I think it's a great way to highlight the amazing work that went into this issue. I think we also have a really broad guest editorial board for this, which is really nice. We have 4 of us who are pediatric rehab physicians, and Rachel Byrne is actually the executive director of CPF. So it's a nice perspective. And we also have 2 of us with lived experience. So I think that really speaks volumes to what we were trying to cover. I think one of the key things we really wanted to touch on was hitting topics that are not covered as often. We hear tons about tone, we hear tons about gait. We wanted to hear about the more broad topics, especially things that actually matter to those with lived experience. And that's why we've touched on having some articles with speech and respiratory topics, as well as opioid prescriptions, looking at orthopedics as we transition into adulthood. So hopefully you'll find that this was pretty comprehensive in topic areas. Justin and Heck Young, anything else you'd want to add?
I think you're right, because we tried to cover more than spasticity, which we were working on for the last couple of years. But I think another one I was happy to see there's some issues on transitioning part. So I think we addressed quite comprehensive issues this time.
Oh, Justin, we can't hear you.
I think the answer.
Oh,
hear me?
Yes, we can hear you now.
Okay. You can hear me, but I can't hear you as well. So in our early conversations, we wanted to focus on the subjects that Suthri talked about, largely the whole person. Sometimes I think CP gets broken down into orthopedic problems and gait problems, as she said, and then neurologic complications. And so I think as a specialty, as a larger medical treatment group, including orthopedics, neurosurgery, all the people, sometimes we do not do as good a job as focusing on the whole person, such as sex, such as community integration. And so that is how we tried to shift this particular edition. And that's all I have.
Yeah, I was gonna say thank you all so much. I think it's really helpful to know not only the articles, but like what goes into it and what the editors are going through the journal. And so interesting and so exciting to hear about the ones that are already published and that are open access and free for anyone to find. Sarah, I think we can go ahead to the next slide. For this one, I think Deb and I were going to trade off. I'll start off by introducing Dr. Spiela Nemo is going to talk about the safety of botulinum toxin injections in children less than 1 year old. It was an original research article, and I will hand it over to her to tell you about herself and go over the article.
My name is Ciela. I think I was actually supposed to go second, so I was a bit confused.
I can jump forward, or we can have.
I think let's start with ankle proprioception. My apologies.
No worries.
So sorry about that.
No worries at all. I'll go ahead and
we're going to hear from ankle proprioception in children with cerebral palsy from Annie Abraham.
Yes, thank you. Everyone, I'm just so grateful for the opportunity to be part of this Speed Journal Club. Just to introduce myself, my name is Annie Abraham. I'm the graduating or outgoing pediatric rehab fellow at Children's National in Washington, D.C. I will be moving to Dallas, Texas in like 3 days, where I'll be joining the faculty at UT Southwestern and Children's Health in Dallas. So I'll be presenting the article titled Ankle Proprioception in Children with Cerebral Palsy, which was authored by Elizabeth Boyer et al., coming out of Gillette Children's in St. Paul and the University of Minnesota Twin Cities in Minneapolis. We can go to the next slide. So knowing that ankle proprioception informs posture and gait, the goal of this study was to objectively quantify ankle position sense acuity in a pediatric CP sample population, with acuity measured by both bias, which was the just noticeable difference threshold, as well as precision, or the consistency of response, which I'll refer back to in a future slide. Go to the next slide. So this was a cross-sectional study in which children with CP and typically developing children performed ankle proprioception testing. So this was done using the ankle proprioceptive acuity system, which is pictured on the left. And in these trials, they asked the child to differentiate whether a reference or comparison position placed their toes closer to the floor. And so by doing this test, this represented a 2 alternative forced choice paradigm, which allowed for measurement of the smallest perceived angular difference. Next slide. So in looking at, one slide back, please. There we go. So in discussing ankle position sense acuity, the just noticeable difference was reflected by the angular difference at which a participant could discriminate 2 different ankle positions at 75% accuracy. And then precision was denoted by the uncertainty area, which was defined by the range of the stimulus size differences between the 60th and 90th percentile probability of a correct response. So seen here is a demographics table of the study participants, which included 58 typically developing children and then 15 children with CP. 13 of those 15 classified as a GMFCS 1 and 2, and then 2 of them were GMFCS 3. We'll go to the next slide. So turning to the data, the study found that the just noticeable difference threshold between the 2 groups was statistically significant in terms of the difference, with a p-value of 0.009, which is shown on the left. But meanwhile, looking to the right, there was not a significant difference in the precision measured between the 2 groups. So really just that just noticeable difference was statistically significantly different. And here, the just noticeable difference threshold data are plotted by age. So 9 of the 15 children with CP had a threshold in the 3rd and 4th quartiles of the typically developing cohort. 3 of the 15 children were actually above the 95th percentile. And then in addition, the just noticeable difference threshold did not relate to GMFCS level in this study. Next slide. So the authors concluded that impaired ankle position sense can be a clinical feature of children with CP of GMFCS levels 1 to 3. They noted that the outcome measures in this study most closely represented like a peer proprioceptive function, as they didn't rely on any active movement for testing. So that helps distinguish between motor and sensory impairment. And then this research sheds light on the prevalence and severity of lower extremity proprioceptive impairment in CP. Next slide, yeah. So with all of this, some of the questions that come to mind include, should we screen GMFCS 1 and 2 patients for proprioception impairment more regularly? Does wearing an AFO interfere with development of ankle position sense? How might tone interventions impact proprioception? Should we be focusing on ankle proprioception as an impairment goal to train? So really ultimately asking, how much should we incorporate proprioception into our rehabilitation plan? And that concludes the first presentation of the Speed Journal Club. Thank you for your time and attention.
Thank you, Annie. Great. Next, we're going to hear from Sila Nemo, and she's at the University of Michigan, and she's going to be talking about a subject near and dear to everybody's heart. And please take it away and tell us a little bit about yourself, Sila.
So good evening. My name's Sila Nemo. I'm the second-year fellow at University of Michigan, and I will be going to University of Nebraska as a faculty member in September. So the title was Safety of Botulinum Toxin Injections in Children Less Than 1 year old, a retrospective chart review. The authors were affiliated with Gillette's Children's Specialty Healthcare and University of Minnesota. And based off this being a retrospective cohort study, level of evidence was a 3. We could advance the slide. The goal of this study was to assess the safety of botulinum toxin injections in children less than 1 year of age. The authors recognized that there were no previous studies investigating adverse events in children under the age of 12 months. And so that's what they wanted to look into. Next slide. So this was an IRB approved study with parent guardian consent for participation. It was a retrospective review with medical records from children less than 1 year of age, with the exception of one patient who was 1 year and 13 days old between the years 2005 and 2018. The information collected included diagnosis, age and weight at the time of injection, muscles injected, dose and concentration of the toxin, sedation and localization techniques, and adverse effects. And they obtained follow-up data from the initial post-injection appointment. Next slide. So 47 total patients were included in the study, 22 male and 25 female. Age range was anywhere from 83 to 379 days old. 37 patients received 1 round of injections and 10 received multiple rounds. The main diagnosis was brachial plexus injury followed by cerebral palsy, clubfoot, salaria, and congenital torticollis. The majority of the patients received the onabotulinum toxin A or Botox. 1 received Xeomin and 1 received Dysport. And the most common muscles that were injected were pectoralis, subscapularis, gastrocnemius, and adductor pollicis. Next slide. In terms of adverse outcomes, 2 patients, both of whom received onabotulinum toxin A or Botox, had adverse events. So the first patient experienced a week of fever, vomiting, and diarrhea that started approximately 24 hours post-injection. They did have repeat injections a year later, and no reported adverse events occurred with that follow-up injection. In the second patient, they had subjective weakness in the muscle injected, which was the right biceps, and they received 30 units of Botox into the bicep at 3.1 units per kilogram. Unfortunately, the severity and duration of the elbow weakness they experienced was not documented, but they did also receive subsequent injections and had no reported adverse events on those rounds. Next slide. So conclusions of the authors. So the results from the study indicated no adverse effects caused by doses less than 16 units per kilogram with Botox, 9 units per kilogram with Dysport, and 4 units per kilogram with Xeomin. The patients in this study tolerated the injections well with a similar safety profile relative to older children. There were some limitations with this being a heterogeneous group with variable diagnoses, muscle sites injected, and dosing, which limited strong conclusions. And it was also a retrospective chart review, so there may have been some underreporting of adverse events. Next slide. So some of the take-home points. Botulinum toxin injections in children less than 1 year of age can be safe in the appropriate context and may change clinical practice approaches for treatment in this age group. There's potential implications for inclusion of this study in systemic reviews for developing clinical practice guidelines, care pathways, and early intervention services. And in terms of insurance authorization coverage, this could potentially be used as a basis for getting FDA approval, since the indication is currently at age 2 or above. And that is the end of my presentation.
Thank you so much for that one. I think the takeaway points are also pretty poignant. We've asked our fellows to bring home things related to the article that may reach into the peds rehab world or our practice, and I think she brings up some good topics there. Our next set of articles, there's a couple on some qualitative research. We're going to have our next fellow, Nayun, talk to us about cerebral palsy and a topic of sexual experiences. I'll let Nayun tell you more about herself and the article. Sorry, you're gonna have to unmute.
I've been talking to myself, I guess. Okay,
A little bit.
So I'm Nahan Kim. I'm the second year fellow at Shirley Ryan Ability Lab in Chicago currently. And after finishing my fellowship, I'll be working at Spalding Rehab Hospital and Boston Children's Hospital. So today I'm going to talk about the article exploring the sexual experiences and challenges of individuals with cerebral palsy by Newell and her colleagues. Next slides. Yeah, so the objective of this study was to investigate experiences of and challenges with and related factors of sexuality and intimacy that people with cerebral palsy are facing. Next slide. So this was the descriptive cross-sectional non-interventional single institution survey study, which was conducted between May 2020 to August 2020. And the respondents were recruited by phone call. The age range was between 18 to 65. And this was an online survey outside of the clinic in a private setting through the Red Cap setting. And they excluded if they are not able to complete the survey independently. Next slide. And the questionnaire included types of CP and their GMFCS level, their education level, and medications. Also included the relationship history, status, sexual activity, masturbation history, challenges related to sexual activities. And they also included the open-ended question, including how would you like healthcare providers to address sexual activity related issues? Also included the question regarding the quality of life scale. Next slide. So there were a total of 40 respondents. The mean age was 32.3, and about 40% of the respondents were male, and 80% were heterosexual, and about like 1/3 of the respondents were GMFCS level 1 and 2, and the other third was like 3 and 4. And 22.5% were hemiplegic, and 27.5% were diplegic, and 47.5% were quadriplegic cerebral palsy risk type. And regarding their sexuality and intimacy, about 45% they were partnered at the time of the study, and about 60% of the respondents said they had past sexual experiences, and about 47.5% said they are sexually active at the time of the study, and about 80% had experience with masturbation, and about 46% said their sexual activities affect positively on their self-esteem. And only 10% had sex education for people with disability. Next slide. So they reported these common challenges during their intimate activity. So positioning difficulty, pain, discomfort, muscle spasms, vaginismus, lack of sensation or pleasure, erectile dysfunction. Next slide. And as you can see in the figure, so their relationship status by their GMFCS level and topographic distribution showed that lower functioning respondents were less likely to be partnered and less likely to have previous sexual experience. Next slide. And regarding their self-esteem related to their sexual activities, so GMFCS level 3 or 4, or diplegic or quadriplegic cerebral palsy patients were more likely to report positive effects on their self-esteem from sexual experiences. Next slide. So in conclusion, so large proportion of the respondents were actively dating, almost 46%, and had past, and almost 60% had reported that they had past sexual experiences. And it showed that sexual behaviors can significantly influence their quality of life and self-esteem. And the study showed that topographic classification was more consistent in predicting dating status and sexual experiences than the GMFCS level. Next slide. So the take-home points from this study, so we need more attention from medical providers about sexual activities for cerebral palsy patients by addressing their concerns, by providing relevant resources regarding these activities, and furthermore, tailored sex education would be highly beneficial for our patients.
Thank you, Nayan. Next, we're going towards Nova. Nova is going to be talking to us about the global health therapy provision. And I'm happy to say that Nova is still at Shirley Ryan Ability Lab, and we're happy to have her as our fellow. So tell us a little bit more about yourself and what part of the country you would like to go to or stay at.
Hello, can you guys hear me okay? Okay, perfect. So I'm Nova Ho. I'm one of the current PGY 5 almost 6 rehab fellows at Shirley Ryan. I'm originally from Houston, Texas, trained at Rutgers. I've kind of been on most of the coast at some point during training. My family's from China, so my parents are retired there, so I'm trying to potentially go out west, but honestly, I'm open to a lot of different places for the job search. The article I'm presenting today is called Tremendous Burdens Often Unveil Enormous Gifts. The experiences of South African caregivers implementing speech with therapy for children with cerebral palsy during COVID-19. The authors are Gabriella Evangelou and her partner Sky Nandi Adams. They're actually both speech language pathologists, and they're practiced actively in South Africa. And I believe Sky Adams is affiliated with one of the universities that I unfortunately do not know how to pronounce the name of, but both are academically affiliated in South Africa. Next slide. The goal of this article was to explore the experiences of caregivers for the children with cerebral palsy in implementing speech language pathology teletherapy during COVID-19 pandemic in South Africa. Next slide. So for the study design, they used a network through social media and also certain providers and caregivers of CP organizations from April to October of 2021 to reach out to caregivers of patients with cerebral palsy who had done the speech teletherapy services. Through these CP organizations and social media, they were ultimately able to recruit 18 caregiver participants in their study. It was a qualitative study. So you can hit next to put more my slide. So in looking for their participants, they had to be a primary caregiver of a child with cerebral palsy. Their inclusion criteria were from children 1 to 13 years old. They had to do the teletherapy program, and then they had to have access to electronic device from which they could either do the Zoom interviews or communicate some of the study interview questions. Next tab. And each participant had to do, like I said previously, the demographic survey. And then because this was a qualitative research study, they had semi-structured interviews, either through Zoom or some of them were tried to go to the home and talk to the caregivers face to face. They typically lasted about an hour in duration per session, and they were always audio recorded and eventually transcribed. But some of the interviews took place for multiple sessions, up to 3 sessions. And part of the qualitative data analysis meant that they had to come up with a way to analyze the transcripts from each semi-structured interview. So the 2 researchers would kind of get together and they would just describe and create a coding framework. So they're analyzing the text from all the transcripts, and they want to use a method called inductive thematic analysis. And they're trying to take the text and then kind of determine what themes are they able to pull from the text that are consistent. And then because there's 2 researchers, both of them go through and look for any disparities. And when there are disparities, they kind of come to an agreement about like what the next, like what ultimate sub-theme or category that particular quote or part of the transcript would be categorized under. And they kind of like do this in different sections for each transcript. Next slide. In terms of the demographics, once again, there were 18 caregivers who participated. The mean caregiver age was 37 years old. 12 of the caregivers were mothers, but they were able to get some fathers as well. Of note, in South Africa specifically, many children with cerebral palsy are in a facility. So some of the caregivers, or 4 of them, were actually facility employees who provided regular care to children with cerebral palsy, but they cared for several children with cerebral palsy at one time. And then just other like descriptive demographics, 14 of the caregivers were employed, but they predominantly had low skilled occupations. And then 17 of the 18 participants received therapy through government services, and only 1 received private therapy. Next tab. And in terms of the children who were receiving the therapy, the study did mention that unfortunately in South Africa, most of the caregivers did not know what type of cerebral palsy their children had. So the majority were an unknown type. And then 3 had spastic, 3 had mixed cerebral palsy, and only 1 had dyspneic cerebral palsy. Next slide. There are several themes that they were able to pull from their thematic analysis. And there's some descriptive quotes on the side, which I will not read each one, but to kind of like summarize. So for the first theme was all about caregiver empowerment through promotion of their child's communication. So because they're doing the teletherapy in home and the parent had to kind of be there to facilitate, they were spending a lot of time with their children. They were actively seeing what techniques the therapists were recommending. A lot of the parents felt like they understood their children and their communication strategies a little bit better. Next tab. Another sub-theme was that there's difficulty renegotiating the caregiver role during COVID-19. So many of the caregivers, especially since so many of them were employed, felt like they were doing housekeeping, they were doing education, they were doing therapy, they were kind of stepping into these new roles that they didn't previously have to take on. And some of them even were like, I'm not a speech therapist, I'm not trained in this. So there was some difficulty in establishing that new role. Next. Another theme is that they would often use available resources in the home environment. So that often was a little bit more contextually and culturally appropriate. Because the therapy was brought into the home, they were able to use things that they were able to find at home. But sometimes some of the parents also felt like they didn't have the same resources that they would have had from in-person speech therapy and like different communication devices or toys. But like being creative with what things that they did have, but also with the limitation of maybe not having everything available. Next. They also felt another theme was that there was a strong need to promote support for caregivers, and just the spectrum of which the teletherapy was brought to the home and feeling like they had to do this by themselves. They didn't have a lot of education going into this. A lot of caregivers described needing more support or lack of support. Next. And the last thing that they have is that they felt like overall the benefits of the teletherapy sometimes would help other children, not necessarily their child that they were caregiving for that had cerebral palsy, but even other children in the community. And they were able to have these learned skills and techniques that that they were able to help other mothers or other children. Next. So there's a few conclusions based on this study about teletherapy and use for speech therapy. So overall, the teletherapy allowed for the children to practice these skills with their caregivers and to incorporate like different parental perspectives so like the speech therapist would have to like constantly interact with the parents to provide the therapy. Next. Sometimes the caregivers also felt that they were better able to understand their children's communication difficulties and kind of the importance of the speech therapy itself. Some parents felt more empowered and closer to their children, partly due to the time spent with them and the one-on-one, as well as through the techniques used for the teletherapy. Some parents had a significant change in their caregiving role. So as we said previously, they had to take on additional responsibilities on top of their ongoing employment and their family care, but now they're also being asked to do these new rehab skills. And kind of similarly, it's difficult to balance the employment and there was not a lot of caregiver support. There was a lot of diversity in the environments in which the teletherapy was being given, and different families had different resources, different toys, different access methods to therapy. And then the skills from these teletherapy sessions translated into helping other children in the community or helping other people with disabilities. Next slide. So I think some of the take-home points that this study was able to demonstrate is that there is a role and an important role for speech teletherapy for children with cerebral palsy, and this specifically was applied in a context of South Africa, but potentially even in other global health settings or in a pandemic setting, like lots of different providers were needing to use therapies. One of the limitations of this study, though, was that most of the caregivers and children who received the teletherapy were in metropolitan areas. So they didn't have a good sample that included rural participants. It'd be really interesting to kind of get a better idea of like other participant types and the role for teletherapy when it's a non-pandemic area and who all out there is still kind of doing this teletherapy. And then another important take-home point is that care needs to be delivered in a culturally and contextually appropriate setting. In this particular case, there was a lot of different considerations for these caregivers who are in low-income settings, trying to juggle their jobs with the therapy, needing to take on that new role as therapists. And then lastly, just as providers who are thinking of parents and their children holistically, we want to think about creative ways that we can support our caregivers in doing and promoting their children and their teachers.
Yeah, thank you so much, Nova. I do have a great appreciation for that qualitative research because it's nice. Often you get a feel for patient experiences or family experiences that sometimes original quantitative research doesn't have that perspective. So I appreciate you presenting this article today. We're going to transition over to our last article, and it's not an original article piece nor a qualitative piece, but really a practice review about musculoskeletal management of cerebral palsy. And our incoming fellow, Lydia, is going to tell us about herself and this article.
Hi, everyone. I'm Lydia Singerman. I am or just graduated from Thomas Jefferson University Hospital in Philadelphia. And as Dawn mentioned, I'll be the incoming fellow at CHOP in just a few weeks. So this was a bit of a non-traditional article. It was more of a practice review, so I tried to boil down and keep this as brief as possible. So the article is Management and Treatment of Musculoskeletal Problems in Adults with Cerebral Palsy, experience gained from 2 lifespan clinics, Mark Katzman et al. And I'll talk a little bit more about the authors moving forward, but all were from well-known institutions. The goals of the studies were to look at the discrepancies in preventative primary surgical care for adults with CP. It's well known that there are more adult patients than pediatric patients with cerebral palsy, but they have decreased access to healthcare, treatment centers, and providers for the specific patient population. So to encourage providers to increase access to care through continuity clinics. The study design, so David P. Roy and Henry G. Chambers from Rady Children's Hospital and Columbia University Medical Center have managed a continuity clinic for adults with CP for over 30 years. They've cared for 5,000 patients. It was not clear exactly if these were consecutive visits. Did this include one-time visits? So the 5,000 patients, it's a little unclear where this number came from. And they related their experiences over time and presented a few cases that unfortunately we just don't have the time to go over today. So some of the findings, so general health. So as I mentioned before, there's inadequate primary health screenings that lead to higher incidence of chronic diseases and medical conditions. Pain and fatigue were 2 of the big ones that plague the adult CP population. But there was also increase in respiratory disease, dental problems, women's health screenings lacking, so higher risk in breast cancer, stroke, mental health disorders, including depression and bipolar disorder. And they also noted 2 ambulatory declines or regressions, one between 20 and 25 attributed to weakness and spasticity, and the other one between 40 and 45 due to musculoskeletal joint degeneration, so wear and tear in the population. As far as tone management and Semmel's with CP, as expected, baclofen and both intrathecal and oral form, as well as Botox injections, were seen very efficacious for tone management. However, it was noted that there need to be further studies for the role of ITP in adults. And adults in general will trend more towards dystonic features, especially in the higher levels of GMFCS patients. And then in regards to the Semmel's procedures, they found that adults had a delay in ambulation recovery, sometimes taking up to 2 years, and the planning that went along with that for long-term care. In regards to the spine, so scoliosis is present in over 60% of adults with CP. This can lead to pain, GI, respiratory status difficulties, positioning difficulties, and ulcer formation. They also found that cervical stenosis had a higher incidence in the CP population, and cervical myelopathy occurred at a much younger age group than the general population. So some of the conclusions that came more out of the cases that we didn't get a total chance to go over, but I wanted to bring up. So as we know, more adults exist and they have higher rates of general medical problems, but their care, as they called it, there was a care cliff for the CP population. When we see a progressive loss of function, weakness in the upper extremity, changes in spasticity, and bladder dysfunction, this should prompt a workup for cervical myelopathy or hydrocephalus. Scoliosis can continue to progress in adulthood and become symptomatic, and the earlier the treatment, the better outcomes for these patients. And then spastic dislocated hips have a higher rate of becoming symptomatic, and the different treatment options that are available. So the take-home point that I took from this was that, as I'm sure everyone knows, that young adults can no longer be seen by their pediatric providers, and there's a lack of adult providers who treat CP and what we can do. And I think coming out of a adult training program and just about to enter my peds program, this question of this is an education we don't get despite seeing CP patients, and we're not educated in some of the complications or timelines that we should be looking for complications in these patients. And should this education be integrated into the adult management? What can we do better to help care for this patient population?
Thank you, Lydia. And now for what we hope is the fun part, is the discussion and conversation. For the ground rules here, what we would like to do is have you use your hand if you have a comment, and Dawn's going to be monitoring the chat function. I want to thank the authors of the papers who have joined us. And as most journal clubs and most articles, there's more questions than answers for many of the papers. I'd like to sort of work backwards. In terms of the adult discussion, I think it's really important because there are some aspects of trying to develop guidelines for adult care in this space by the Cerebral Palsy Foundation. It's very difficult to find a population study. So I do feel that the review of large populations do provide information, and would like to ask Hank to come off mute and give us a few words of wisdom on his adult perspective.
Yeah, thank you. Thanks for inviting me. I've enjoyed this journal club. Yeah, as you all know, that's one of the biggest problems is how do we take care of adults, and how what can we do to help? I've been working on this for like 25 or 30 years trying to get adult providers, and I really think that looking at all the different models, that the rehab doctors are the ones who have the best way to do that. We have 2 full-time rehab doctors that are taking care of our adult population now, and all the other ones like med peds they're a little bit interested in helping, but they just that's just not where they don't have the training in that area either as well. So I think your specialty is the one who's going to help take care of this. But as we mentioned in the article, there's just a lot of things that especially in the musculoskeletal system, that y'all don't get the training in. And that's why we wrote the article, just things to look for, like the hip dislocations still can happen in adulthood, that foot deformities can get worse in adulthood, all these kind of things that sometimes aren't looked at because y'all are taking care of all the other problems. I think the one I've been trying to write a study because I've just doing a quick review of the charts. I found that about 20% of my adult patients have bipolar disorder, which is a huge number. But if you don't ask the questions, you don't know. You won't be able to, I mean, if you don't ask them, have they not slept for several days? Are they suicidal? I guess we do ask now if they're suicidal, but even if they're just depressed, do we ask that question enough? So I think it's obviously a big challenge, and that's why we're trying to put things out like that. Dr. Roy and I talked about when we were doing this. I mean, if we just put out a bunch of statistics, I don't know if that helps anybody. So we tried to write a review article. We really wanted to thank this journal for for this special edition, for letting us at least put out our experience over the last 30 years.
Yeah, and I think it serves to give enough punches for a better population study, say for Cerebral Palsy Research Network at Sutri and Hyekyum are involved with. Hyekyum, you've got your hand up, and I'm sure you've got some good comments for us.
No, I mean, I'm trying to build adult CP clinic in Dallas at this time. And because I have experience from Colombia and transporting that experience with the knowledge in Dallas, which has been extremely challenging because I know, Hank, you're telling us that PMNI is good. Of course, PMNI can be the best specialist to cover those patient population. But as I found the problems in adult with cerebral palsy, we really need all other specialists has to be included in that endeavor because especially like Hank, your case, I have no orthopedic surgeon who can take care of adult with cerebral palsy. I can find problems, I can triage them, but there are no other specialists who can understand their problem or who are willing to take care of them. Especially, I don't know, it's Texas issues, but I'm hitting the wall, and I'm glad that we have a group of people, we are working on this piece, but I just want to say that PMNI is ready for that, but the counterpart, they have to be ready for us too.
I totally agree.
Sally, you have a comment?
Yeah, it's slightly tangential, but Hank, I'm interested in a comment that I heard from your paper. I didn't read it, full disclosure, but saying that the dislocated hips could become more painful in adults. And I'm under the impression that there's a window of time during which dislocated hips can be relocated, but that's fraught with the possibility that the surgical correction might be worse than the situation, that if hips aren't painful, don't put them back. What's your sense now, having seen the adults in this situation? And to Lydia's point, how do we educate those of us who are taking care of the children and stopping at that point about what might happen when they're adults?
Yeah, I totally agree with that. I think we did a point counterpoint at the CP Academy about 15 years ago, because there are a lot of orthopedic surgeons who somehow have taken what we do in spina bifida and transported that to cerebral palsy. Because kids with spina bifida usually don't get painful hips, but almost all kids as adults get painful hips, and they may not get it until they're adults. So the pediatric orthopedic surgeons see a 15-year-old with a hip that's out, and they go, well, this kid's going to no problem. And so having an adult clinic since 1995, I learned that I'm much more aggressive. So there's this sweet spot under the age of 12 is the best time to do it, because if you wait much longer than that, the cartilage wears off, and then you can't do a simple operation. And all the salvage operations that we do are terrible. There's not a good one that we do. Even though it eliminates some of the pain, it doesn't completely eliminate the pain. So we're very aggressive. And if you get it in before 12, the oldest I put in is probably 15 or 16. But if you do it, if you wait too long, you can't do the simpler operations. I know they're still big operations, but nothing compared to the salvage procedures that we put in the article.
Thank you. And then if you try to find someone to do a total hip, you really have to search hard and long.
And the total hip complications in adults are terrible, because they have dystonia, and they pop their hips back out, they get infections, their bones are small. So you want to do the right operation early. So you have to find a good pediatric orthopedic surgeon who really will be very aggressive at a young age.
Catherine, do you have a comment or a question?
Yes, I do. Thank you. Can you hear me?
Yep.
Yes.
Okay. So I'm peds physiatry in Akron, Ohio, and I just wanted to mention that one of the things that's occurred to me about trying to do adult transition that I've found the biggest barrier is that other specialties simply don't feel comfortable working with people with disabilities. And so as I tried to process what would be the best way to try to make an inroad in that regard, I thought about medical students starting out, because as I reflect on my training, I really didn't get any exposure to working with individuals with disabilities until I actually did my rehab training at Thomas Jefferson, by the way. So I remember one of you was from Thomas Jefferson. But I have had the privilege of now being a part of a community advisory board to our local medical school that is working on this very issue, incorporating, working with individuals with a wide range of disabilities, be it mobility, vision, hearing, neurodiversity, so that our medical students feel more empowered and more comfortable, even knowing how to interact with individuals with special needs. So I'm hopeful that's going to make a big difference. And I think it would be great to see that type of an approach, spread throughout the country.
I think that's a great idea. And I've worked with a group that's actually lobbied Congress on this because, the CMS, or is it CMS? Yeah, the Medicare, Medicaid, help determine what the curriculum is. And if you can get someone from the top that says you have to have 10 hours of disability training, because right now every school does whatever they want, like you said. So having your school at Akron do that, or at my UCSD, even though I'm a good friend with the dean, he goes, well, that's not my job, that's the curriculum department, and they can't do anything. So I agree that's the way to go, but it's even hard to do something simple like that. You would think that would be pretty simple to do, to add on, but I appreciate you're working on that.
Very creative. We could probably talk for 10 minutes on each paper. Anybody else have comments? Because we want to be very respectful of your time. And we're learning a lot. We're going to ask you to fill out a survey if you like this format, if you'd like to be part of it. And we'll have that in the chat. And Sarah, maybe you could put that up. I wanted to thank the team from Gillette. I could probably talk about that one for about 2 hours, but nobody wants to hear me. The other thing is, one thing about a journal club, it provides you the opportunity to look deeper into a topic. And I sent some supplemental material to Sarah and Dawn if you're interested in some of the other spin-offs. So Dawn, do you have other things you want to?
Yeah, I'd love to. Sarah, if you don't mind forwarding, there's just couple other opportunities that I would love to talk to you guys about. So opportunities both for our pediatric rehab medicine fellows, our trainees, as well as our attendings and physicians been in practice. We can go to the next slide. The JPRM has a mentor-mentee program for article review, for peer review. We have guidelines to help both the fellow and the mentor to help them work on one of the JPRM submissions together to work on a peer review process. Our recommendation is the commitment's about 2 or 3 sessions with the mentor-mentee process, and then you would submit to the Journal of Peds Rehab Medicine. So if it's something that you're interested in and being a part of, you can email the managing editor, Sarah Tinsley, about that. And additionally, you get at the end of the year credit in the JPRM, being a part of the mentor-mentee program and being a part of the editorial team. And then we can go to the next one. This journal club was brought to you from our resident fellows panel. So our resident fellows panel, we're always looking for more trainees. We really gear it more towards fellows, but any residents that are really motivated in pediatric rehab medicine, or even in being a part of medical literature or journal review, we're welcome to take anyone, and as faculty members as well. But our resident fellows panel, we work on outreach for the journal that includes presenting at AAPM&R this year. Our fellows panel will present the Jacob Newfield Award at AAPM&R. We are working on a podcast that the resident fellows panel is a part of. We're working on our social media outlets access. So really, if there's any area of expertise that you have, we're probably interested in helping the JPRM. So again, reaching out to Sarah Tinsley. to let her know that you want to be a part of the resident fellows panel in the fall or late summer, early fall. We'll reach out to our program directors to directly give some more information for the incoming Peds Rehab fellows that haven't started yet. And then last slide, I think was the first part was to say stay tuned, because I hope this is the first of a series of our speed journal clubs. The AAPMR hosts monthly journal clubs, and in July, Dr. Elliot Roth is giving a great lecture on how to do a journal peer review. So I would try to catch that next month if you're able to. And Sarah put the link in the chat about our feedback form. If you have a chance, take a look at the feedback form and let us know. And I apologize, as I was talking, a bunch of chats came in. Oh, just a lot of people saying thanks for coming. And one comment on the sexuality article.
Yeah, and I've got a booklet I can send you, Sutri. If you email me, I'll send you a copy of it. And also, Cerebral Palsy Foundation, I think, has quite a bit on sexuality. So I would check their cprootsource.org. And I'm happy that everybody is interested in cerebral palsy. So we'll see you in Quebec, right? That's what the meeting is, and hopefully we'll all keep learning together. So thanks, and thanks, Dawn, for spearheading the effort.
Yeah, thank you all for celebrating your Juneteenth holiday with us.
Yes, thank you. Thanks, everyone.